Good afternoon. Welcome to P3 Showcase number 5, From Private to Public, Lumeca's Virtual Care Journey. My name is Marissa Binstock, and I'm Manager, Member Programs and Services at Digital Health Canada. I'm thrilled to be the moderator of this P3 Showcase sponsored by Lumeca. This session will consist of a live presentation, and if we have time for questions, we'll address those at the end of the presentation. So use the chat box if you have any questions. I also encourage you to connect with the speakers after the session via the virtual event platform. Joining me today are Tom Douglas, an experienced serial entrepreneur with a track record in successful ventures for the last decade. From 2013 to 2018, Tom built and scaled software as a service company S Media with partners to a $32 million valuation. After his exit, Tom began a consulting firm for startups, including Store to Door, Home Team Live, and Lumeca Health. In April of 2021, Lumeca's board and key investors asked Tom to join the team full-time as COO. Under his leadership, the team transitioned their offerings from a virtual medical service provider model to a SaaS-based model and secured a milestone multi-year contract to provide virtual care tools to the province of Saskatchewan. Tom was promoted to CEO in February of this year with a vision to grow Lumeca International. Joining Tom is Cassandra Klassen, and she has over 20 years working in healthcare, including acute care, long-term health, mental health, virtual care, and teletriage. Cassandra combines her health information background with project and change management to lead clinical information systems implementations, teletriage program design, and transformation projects. In 2017, Cassandra became the director, Prairies branch for Jeopardy Consulting, Inc. With the recent acquisition by Accenture, Inc. in 2022, she continues her role as principal, Prairies Health. Cassandra is based in Regina, Saskatchewan, and is active in the community through various volunteer activities, including board chair for the nonprofit Street Culture Project, an organization that serves at-risk youth, and currently sits on the HIMSS Prairies chapter board of directors as a Saskatchewan member at large. So let's get this conversation from private to public, Lumeca's virtual care journey going. Please join me in welcoming both Tom, CEO at Lumeca Health, and Cassandra Klassen, Principal Prairies Health Accenture. I'm going to pass it over to you, Tom.
Thanks, Marissa. Hello, everyone. Before I jump in here, a quick land acknowledgement. I, as well as Cassandra, we're both calling in from Treaty 4 territory today, which are the original lands of the Cree, Ojibwe, Saulteaux, Dakota, Nakota, Lakota, and the homeland of the Métis. So for the talk today, what I want to talk to you guys about is our story. And it's a story of entrepreneurship and ingenuity. It's the story of how Lumeca went from being a private virtual care company to being the virtual care software for the province of Saskatchewan. So my hope for today is that you walk away with some new insights about how the public and private sector can actually work together to accomplish some important goals, namely increasing access to appropriate care, and also how virtual care technology can actually help unattached patients roster with family physicians. And so today's format is going to be a bit of a narrative. And if I'm doing my job by the end of this, most of what I'm telling you should all seem like common sense. There's obviously a lot being talked about this conference on virtual care. So before I jump into straight into Lumeca's journey, I'm going to talk about my background so you guys know where I'm coming from and who I am. So I actually come from automotive. I'm the new guy here. I'm not an MD. I'm not a seasoned health exec. I'm a serial entrepreneur. And this here is a picture of myself in university with 4 of my business partners. It was my first software company. And we're holding up a press release for a piece of software that was an absolute flop. We fell into the trap of thinking we knew what our customers wanted, what the end users wanted. And what ended up happening was I salvaged the data for a press release. Because the data was interesting, but nobody wanted to use our tool. But fast forward this to 5 years of being in the trenches and learning in the tech space, And we'd made the Growth 500 list in Canada. We had a $30 million company. We had hundreds of clients using our software. And the secret really wasn't a big secret. You know, a lot of the guys who play in software long enough eventually learn that you got to listen to your customers' problems. You have to listen to, in this case, the providers and patients' problems in virtual care. And I know it seems obvious, but they don't always know how to solve them. They know what their problems are, but they don't always know how to solve them. And as software designers, as architects of a new way of doing things, we have to innovate and find new ways to solve old problems. Henry Ford has this great quote, and I always bring it up when I'm talking about software. Henry Ford once said, if I would have asked people what they wanted, they would have said a faster horse. So when I joined Lumeca, one of the first things I noticed was that everybody kind of wanted the faster horse. You know, we all knew that we needed to implement virtual care very quickly during the pandemic, and virtual care had been around, but a lot of people made the assumption that what we needed was a video room with, you know, clinical grade security or medical grade security. And right away, so I got down to business. I dug into, you know, what were the preconceptions. I spent a lot of time talking to physicians, a ton of time. In fact, I think the first 3 or 4 months of my job consisted solely of that. So one of the first things I realized coming from automotive, and this kind of was a shock to me at the time, was that change in medicine is really slow. Like I'm talking painfully slow, and not to insult anyone here. I mean, there's good reasons for it, but it took 20 years for the stethoscope to gain any traction in the 19th century, and even longer for hand washing to become a normal part of medicine. So the pandemic, you know, this was an interesting time to really get into the medical space, was really pushing things at warp speed. And what I learned very quickly was that change can be risky. You've probably all heard the expression, especially in medicine, no one gets fired for buying Microsoft. Well, in digital health, that seemed to be the case at first. And so sometimes, interestingly enough, it can take things like a global pandemic to really catalyze change. So when I began my consulting work for Lumeca, because I started off as a consultant, I dug in to try and see what some of the perceptions were around virtual care. And it's very interesting. So the first thing I learned was that virtual walk-in was a swear word. If I said that Lumeca at the time was operating a virtual walk-in clinic, you know, I would get scoffed at. And another one I got a lot of was that virtual care was inferior care at the start of the pandemic. And I think everyone's come to realize that's not the case. And now it's a question of appropriateness. But when I started looking around, another thing that I got was that a lot of physicians were under the impression that telehealth was creating a lot more work for them. Or the worst one that I got often was that, you know, these private companies in telehealth, their main concern is making money, and they're fragmenting the healthcare space with no regard for the patient. And so what I'm hoping to do today is I'm going to explain my story to you, talk about, you know, where we came from and where we got to, and you know, maybe address some of these preconceptions. And like I mentioned at the start, find a way that the public and private sectors can actually work together to solve some of these problems. So Lumeca's story is broken up into 3 phases. We were originally a benefits service. So this is before the public fee codes were introduced. We were selling to companies, to employers. Then we were a same-day access clinic, which is what marketing likes. They don't like when we say virtual walk-in, but in reality, that's what we were. And then Lumeca became a software as a service provider. And that's where we are at present. So I'm going to dig into these 3 phases and talk about what we learned along the way. So really, when we were a benefits service, we were spun out of our sister company, which operated in oil and gas and mining, and they had a lot of clients who had remote work sites, places where it really didn't make sense to fly somebody out of camp or for have them drive a day to go get a prescription refill. So that's how Lumeca was born, and patients loved it. Employers loved it as well. But doctors were really critical at the time. You know, change is slow. And a lot of doctors even told us at the time it would never work. But this is where we first saw our insights into the problems with continuity of care. We had built a virtual care system, and we were having to print out soap notes, walk them over to a fax machine, and then fax them over to the family doctors that these patients belong to. And faxes were failing. You know, it's 5% of faxes fail. So this is really eye-opening for tech entrepreneurs and tech enthusiasts to have to deal with these kind of problems. So fast forward a little bit, the pandemic hits, March 11. We had been trying to sell to crown corporations in Saskatchewan, so they were well aware of what Lumeca was about. And the ministry approached us on March 11th after the pandemic was declared. They said, can you help? You know, we know you've got a service in Saskatchewan. Can you deploy that public facing? So on March 19th, We spun it around. That's 8 days later. So it was a few all-nighters in terms of our tech team, that's for sure. So we ran a modest-sized clinic. You know, we had a lot of new patients. We service up to 190 patients a day. We're open 7 days a week. One of the most shocking things that we discovered right off the hop was that a ton of patients who were coming to us did not have family doctors. So we had about 37,000 users. So if we were a city, that would make us about the third largest in Saskatchewan, just to give you an idea of the size. And we delivered about 25,000 consultations. Patients loved the service. In fact, they lamented it when we finally spun down our walk-in service in Saskatchewan. Some doctors were still critical, but at this point, virtual care and quality care were no longer antonyms. We still had some big struggles with continuity of care though, and it was especially due to the facts. So remember how I said change was slow and the stethoscope took 20 years? Well, I really hope that it doesn't take 20 years for the facts to finally disappear across Canada in medicine. But so we were tired of sending things via the fax in Saskatchewan. We suggested a portal to the college. We suggested secure email. We investigated integrations directly into the provincial health record. But for us, a small startup at the time, a $500,000 price tag and a 2-year timeline was just something that we couldn't stomach, not as a private startup. So what did we do? We did our best. So we took an eFax system and we integrated it into the platform. It was a sort of the best we could do under the circumstances. And what we did was we created a follow-up system inside the tool to basically prevent any faxes from falling through the cracks. So we had a follow-up system motivated by the Greg Price story, actually, to make sure that at the very least, if we were going to be stuck on the fax, that we would at least have reminders to follow up and make sure that referrals were done. So we didn't let the facts dissuade us, though. In fact, we were hell-bent on making the best virtual care experience we could, and our patient satisfaction scores were great. 88% of people said they would recommend us to a friend or family member, and this was kind of in line with what the CMA was seeing in terms of patient experience on virtual care. And this is nothing new for you guys. Like, pretty sure everybody here knows that patients love virtual care. And not only that, most patients have tools to access virtual care. It's 87% of Canadians have at least one smartphone in their house. 84% have one household computer, and 96% have the internet. And I know that equitable access is a big deal for a lot of people, but the solution's simple. You go out and you do something about it. So here's Lumeca out at Cowessess First Nation, Chief Cadmus to Lorne. We installed the pod out there. They had little to no cell service at the time. And so we installed the pod in the band office where band members could come and access care. And then through collaboration with our local telecom, SaskTel, we were able to increase the cell coverage out at Cowessess First Nation. So anyways, solutions exist. We can do it. But what was happening inside Lumeca was at a sharp contradiction to what I was hearing from all the family physicians and brick and mortar clinics that I was talking to. Because inside Lumeca, physicians were having a good time practicing care. They were enjoying their practice and they were seeing a reasonable amount of patients. But outside of Lumeca, the overwhelming feedback that we were receiving was that telehealth was more convenient for patients and not for providers. And this McKinsey & Company survey really backs that up. So in Lumeca, and again, there was this sort of sharp contrast that I needed to get down to the bottom of. So in Lumeca, the average doctor was seeing 4.5 patients per hour. And there was a lot of new patients. Mind you, we had mental health consultations in there as well, and a lot of first-time patients. Ronan here, who really enjoyed the platform, family doctor in Saskatoon, he saw about 5.5 patients on average. So again, this was kind of a sharp contrast with what was going on outside, because we were hearing that virtual care was kind of cumbersome for family practice in the community. In fact, 70% of the virtual consults last year were done over the telephone. That means only 30% were done via a video tool. And if you look at the virtual care landscape, more than half of the players are service providers. That means more than half of the players are actually staffing their own clinics and their own doctors and running them in their platform. So you can imagine how much video was actually done by brick and mortar family practice clinics in the communities. So, and this is from the McKinsey & Company survey, and this was North America wide, but only 41% of providers actually believe that they had the technology to deliver telehealth seamlessly, and only 36% of them actually found it more convenient. So this is where I really got to put my skills to the test as a tech entrepreneur and figure out, where the market was going, what were the the pieces that were lacking. Why were physicians inside Lumeca having, an enjoyable practice of medicine, seeing, the same amount of patients as they would in person, but why were physicians in the community having such a hard time with video? And at the same time, the market was sort of regulating against standalone virtual walk-ins. Nova Scotia, Alberta, British Columbia, Manitoba, and my home province of Saskatchewan, they all imposed some sort of restriction on standalone virtual care. So on one hand, the market was sort of pushing towards wanting virtual care to be the purview of family practice clinics or clinics in the community, or at the very least collaborate and have an in-person location, while at the very same time, those clinics on the other side of the equation were saying, we don't have the tools to do video. So quite a conundrum here. And we dove down into that, and our market intel showed us that the video failure rate for consultations, so that means attendance rates, was anywhere from 24 to 50%, depending on the tool. And some of these were integrated. There were some integrated tools that were still failing at 40%. Now, Lumeca, over the 20 months that we operated our walk-in clinic, we got about 21% fail rate. We started at 28%. We got it down to about 5%. And what it boils down to is physician time is not the same thing as regular time. And to give you guys kind of a little bit of just a barometer here of what that fail rate looks like, an outbound salesperson, so somebody who's actually calling business to book an appointment for a sales call to show you their software so they can sell it to you, their fail rate, once you've accepted the meeting, should be about 20% is the industry standard. So we had a serious problem here. A physician fail rate was higher than an outbound salesperson. So Lumeca at this time was, a walk-in contemplating becoming a software provider. We decided we were going to tackle these two problems. So one was this high fail rate, this high unattended rate for consultations. And the other one was this large group of unattached patients that we ourselves had discovered within our platform and had realized they were coming to us because they had nowhere else to go. So on the first problem, let's dig in. So again, I mentioned like 70% of the virtual consults last year were done via the telephone. That means only 30% were done via video. And I mean, why is that? Well, physicians, it's fairly simple. Physicians want to be patient facing all day long. They don't want to play tech support. And if a virtual tool is less efficient than a phone call, guess what? You've lost them. If it's got no integrated scheduling, you've lost them again. Nobody wants to manage two calendars. If they end up playing tech support, even for 5 minutes, for a fees for service doctor, nails on a chalkboard. Not only that, from the patient side, the patient experience is terrible because doctor time is a fluid thing. I'll give you an example. So let's say I have an appointment at 3 o'clock. My physician calls me at 3:30, but by that time, I'm picking up the kids from school. And now I've missed that call. I call back to the front end. I wait for 30 minutes to get through to the office manager to book a new time via telephone. And we both just wasted time. And the same thing was happening with video. If you just had a simple video room link, managing those expectations became quite cumbersome. So what was the solution? Well, you remember I was talking about that faster horse? Well, the solution wasn't the faster horse. It wasn't the better video with more security. It was actually a whole other set of features entirely. And it turns out it's the waiting room. I mean, it's kind of funny now with the aha moment after you realize, but at the time we expected to be able to give physicians a meeting room link and send that to the patients and have everything work out hunky-dory. When in reality, can you imagine a clinic run by physicians alone without office admins in the mix? What happens in real life? Right? The patient's held hostage. I mean, it's not a great patient experience. Nobody's here to try and convince you of that, but the patient's held hostage and the patient waits on the doctor. The doctor doesn't wait on the patient. So in real life, a physician goes and they open a door and there's a patient and they're patient facing and they get down to the practice of medicine. And when they're done, they walk to the next room and they open the door and the patient's in there. And the whole time they have confidence the patient's in the room. This is key component to actually achieving the same efficiency as in person. So here's what we did. We took what we did in real life. We involved the office administrators. We involved a system of rooming patients where you can see if the patient's in the room in advance. And if they're not, you can prompt them. We allowed office administrators to go in and chat with the patients in advance to prep them, things like screening or what have you. And what that did was it enabled physicians to jump constantly to the next available patients. People are going to miss meetings. That's a reality of life. And schedules need to be flexible, especially in a physician office. So we built a waiting room built around that. And we saw that the failure rates decreased significantly with this technology. And again, that was our story of decreasing failure rates. So that was one of the big learnings. One of the big learnings was that we cannot neglect the administrators and the waiting room. That's the key component in all of this. So here's some great stats that came out at the start of the pandemic from Frieza. Frieza in the US does patient intake. And what they found, and in the chart, you can see the green line is large clinics, they've got over 100 providers, and the blue line there is your small clinics, brick and mortar, 5 or less practitioners. And on the left is percentage of video visits compared to total visits. And what you can see at the start of the pandemic is everybody starts to adopt video rather quickly, but only the large organizations actually sustain, somewhat high degree of video visits, whereas the smaller organizations can't. And what they found when they dug down on this, it had nothing to do with the amount of providers. And it had everything to do with the amount of tech support personnel, the amount of people involved in change management, and office administrators, because all of the heavy lift in coordinating virtual care. So problem number 2, all these unattached patients, what were we going to do? So we have a fantastic chief medical officer at Lumeca, and right away, when he started seeing the unattachment rates in our platform, he sounded the alarms. He says, we got to get these patients to family practice in Saskatchewan. We got to find them a medical home. So, some other presenters have talked about this today. This is nothing new to you guys. We have a lot of unattached patients in Canada. In Saskatchewan, it's close to 2 in 10 patients. In most provinces, it's closer to 1 in 10. We're the third worst in Saskatchewan, as a matter of fact. And it's a big deal for rural and remote. Of almost half of the unnecessary non-admitted emergency room visits are actually from rural patients. And there's, a study's been done on what's called the distance decay effect. Pretty basic concept, but what it states is that the further you are from care, the less care you're going to receive. So unattached patients are expensive too. It's $200 million annually. And if you work that out per patient, it's $53 a patient per year. So, in layman's terms, every single one of those patients who's unattached, some doctor somewhere is redoing a consultation. They're redoing someone else's work. If you want to conceptualize what kind of money is being spent there. So I would tell you a little story here. So as we were contemplating winding down our walk-in clinic, I started to call every clinic that I could get my hands on that was advertising they could take on new patients on the health authority websites. And to my absolute horror, most of them told me they weren't taking on any more patients and that their name just hadn't been taken down from the website yet. So I called clinics that weren't on the list, and we had a fairly large database of clinics by this time. And again, most of them weren't taking on new patients. So I rephrased my question out of desperation. I started asking clinics, can you take on 20 more patients? And I was actually quite surprised when most of them said, well, Dr. So-and-so, he can take on 20, or Dr. such and such, she can take on 10. And I thought, well, that's really interesting. I got to get to the bottom of this. So I started asking them more and more about why they weren't advertising and how many patients they could take on. And what it came down to was office administrators in most clinics were the biggest bottleneck. Patients are waiting on hold for 30 minutes. And to add an influx of patients all looking for family doctors to advertise by traditional means would overwhelm the front end. So we decided, well, there's got to be a way we can solve this with software. If there's some room in the panel, and we can reallocate this, and we can book people directly into the calendar and not route them through the front end, there's got to be a creative solution here. So that's what we did. We built a map-based feature. We called it our Find a Doc solution. And we allowed physicians to go into the platform, in most cases, their office administrators, to go in and say how many patients they wanted to take on. And they would appear on a map for patients looking for family physicians. And where this becomes powerful is because if you're a rural patient, it's better to have a family physician who's an hour away, heck, even 2 hours away, worst case scenario, that you can see virtually and drive when you need to see them, than have a virtual doctor who's 6 hours away and it's impossible to see in person and they've got to get your records somehow across to that other clinic. So the Find a Doc feature, we betaed in Saskatchewan. We successfully attached 257 patients. We think it has massive potential to utilize existing Slack within the system to help people in rural and remote locations. So can virtual care increase access? Can it help people find patients? Or can it help family doctors and patients connect? Yes, absolutely. But I think the major limiting factor is interoperability. It's really the elephant in the room. It's the true limiter in virtual care. What's the point of making care more convenient for providers and patients if we're still going to find ourselves performing the same consultation multiple times with multiple providers who can't access each other's notes, or God forbid, we're still using the fax machine in 5 years. So actually, there's a great quote on this, and I believe interoperability needs to be funded by the system. And Dr. Heidi Fell from the Alberta Medical Association, when I had the good fortune of chatting with her, she's got a great quote, and she says, benefits accrued by the system need to be paid for by the system, and interoperability and the benefits of continuity of record are benefits of the system. So if we want family doctors to have access to hospital records and hospitals having access to family doctor records, we need to put our money where our mouths are and fund interoperability. Private companies, they have little to no incentive financially unless there's a contract in front of them to do so. There's competitive reasons that some companies don't go down the interoperability road. So we need to fund it. It takes work. And it takes development and it takes collaboration. And fractured healthcare was a problem long before virtual, and it's going to stay that way if you don't get our priorities in order. So that brings us to our present journey and where we got. And I have some good news. So we went and we bid on the RFP in Saskatchewan. We had a proven technology already of 37,000 users. Like I said, that would have made us the third biggest city in Saskatchewan. And now our tool, it's waiting room functionality. The province is eager to start deploying this. We're in the middle of rolling it out to 3,500 providers. And this is where it gets really interesting because there's all this potential, right? We have some integrations planned, and we have a province-wide platform where we have the potential to connect family practice, hospital systems, the provincial EHR. All of that potential is there. And, if funded, if properly stewarded, this can be something absolutely incredible for patients. So for the final topic today, one of the big missing ingredients, and I alluded to it earlier, is all of the work that goes in implementing these kind of tools and the change management. So for that, I'm going to kick it over to my associate, Cassandra Klassen from Accenture. So Cassandra, take us away.
Thanks, Tom. That was really great. So I just have a few slides, but really, and I guess I need to advance the slide. I forgot I have that option. So really the partnership between Jevity, or I guess now Accenture, began last year, almost probably a year to the date. So I moseyed into the Lumeca networking booth and just started chatting, introduced myself, said I was from Saskatchewan, really think your product is great. And we just started talking about some of the key challenges with virtual health and healthcare. So we decided to take our conversation outside of the conference, and from there we started working together and having more conversations and getting to know about each other's organizations. So once we started meeting more often, it made sense to partner with this upcoming RFP. So from Lumeca's perspective, Accenture, or Jevity at the time, really had that in-depth implementation and change management experience. And then our experience within the province of Saskatchewan, from virtual health, really focused on public health within Saskatchewan. And Jevity at the time was very involved with the COVID-19 response with the healthcare organizations. So when combining Jevity and Accenture's experience, and then combined with Lumeca's Made in Saskatchewan product, and their success story, it really made sense, and it was a natural fit, and in the end turned out to be a winning combination. So after we partnered with the RFP and were successful in that, conversations furthered as we continued to plan out for the project, and even planning for this presentation. One of the key themes that emerged was implementing virtual care in health systems. A lot of the focus needs to be on that change management aspect. So the next couple of slides are going to focus on some of Accenture's key takeaways from virtual health deployments, and then some of the key principles to consider when looking at a virtual care strategy. So first off, virtual care is not a Band-Aid. It's a multi-specialty service, and it's delivered in multiple care settings. And right off the bat, the first piece is patient navigation. So the healthcare system is already complex to the patient and can already be daunting. So patients have a hard time navigating the health system, and adding virtual services is not enough if patients don't have the support needed to access the right services. And one of the things Tom addressed earlier too is virtual health is not always equitable, and there are solutions around that, and we need to address those challenges. And the health system proved that we can rapidly deploy and deliver virtual care, but it's still very episodic in nature. So we need to make that care efficient and effective. Next is integrated services. So the health system, as Tom alluded to earlier, is already fragmented. So adding in another unintegrated virtual service without the appropriate integration and collaboration puts undue pressure on the patients and the providers to keep everyone informed about that care. So the combination of patient navigation and integrated services ties into continuity of care. So a virtual health strategy or program that focuses solely on episodic virtual visits is unable to make services accessible to the complex patients that need it the most. So thinking of those people with chronic conditions. So this is going to really require an investment into virtual health and to the health system. Three other takeaways from virtual health deployments is that the elephant in the room, as Tom spoke to earlier, is that interoperability infrastructure. So there isn't a one-size-fits-all solution for all models of virtual health. And so it's likely that there's going to be a multi-vendor approach that is needed. So vendors are going to have to work together and have their solutions integrate together. And if we're able to do that, this is going to achieve better outcomes for both patient and provider. This will only be scalable and clinically appropriate if the appropriate interoperability infrastructure is in place. The next one is provider burnout. So with the introduction of virtual health solutions without the appropriate integrations and documentation tools and access to patient information, it does combine to provider burnout. So Tom was mentioning, running to the fax machine, and there aren't integrations with EMRs into virtual solutions. So that does add an extra layer of administrative and work functions for providers in their clinics. And then finally, incentivizing the behavior. So virtual health solutions will only get the adoption and support from clinicians if there's enough to gain and do so from financial and clinical perspective. Many of the programs have failed to incentivize the right behavior and achieve the outcomes that they had hoped for. So, again, earlier in the presentation, Tom mentioned that there's restrictions put on virtual care. And, hearing in the news and at the beginning, around March 2020, when the pandemic really got started here, policies were often getting in the way and providing barriers to the virtual visit. So for example, provider billing codes was one of the hot topics and probably still remains a hot topic today. So those were some of the key lessons learned from virtual implementations. The last slide here is just going to focus on Accenture's perspective. So key principles of a virtual health strategy. So again, starting right off the bat, looking at that patient experience and the continuity of care. So a virtual health solution should limit the onus on the citizens to make the right choices about the services they need. Patients must feel like they're in control of their care. We need to empower them when they're making those healthcare decisions. So when developing that virtual health strategy, there's some considerations that need to be taken. So how will care be organized and entered around the patient? And how can the health system create a seamless navigation of virtual and the traditional brick and mortar health services? Then you need to focus on the model of care. So virtual health presents the opportunity for new models of care, and it's likely going to broaden the circle of care as well. We need to develop a model that adds value to all stakeholders, and it's going to be key to driving the right behavior. So how do we blend that virtual and in-person care to patients so we can achieve the best outcomes and high quality care for staff? So some of those key considerations, again, when developing or refining your virtual health strategy is how will virtual health move beyond that episodic care? How will a network of providers be leveraged? And how will the health system drive and facilitate team-based care and integrate with other services? And then again, we come back to interoperability and architecture. So we need to create that appropriate infrastructure. So shared services, standards. It's really going to be key to driving that modular technology stack that drives information exchange across providers. So some of the key things we need to look at is the current infrastructure set up to stand up virtual health solutions. What shared services are required to ensure scalability, and how will providers exchange information across platforms? And does the virtual health strategy align with your digital health strategy? Those two need to mesh well in order for success. And then we come to the information model. So as we've learned, clinicians can only operate in a team-based model if they trust the information that's available to them. So an information model that can be easily utilized across virtual health use cases is going to drive that feasibility and patient safety. So again, when developing or refining that virtual health strategy, how will data flow across the health system and maintain its integrity? How will data be standardizing to enable sharing? So what are those minimum data sets and minimum data standards? And then the patient, patients love having access to their own information, and it helps them feel empowered when they're making decisions about their healthcare and feeling informed about their own health status. So how will patients access and utilize their own data? And then finally, the last piece to consider, principle of a virtual health strategy, is the payment policy and accountability piece. So that appropriate remuneration and policies needs to be in place to incentivize and enable providers, administrators, and vendors. So again, those key considerations is how will virtual health services be compensated? So that ongoing care versus episodic care, and what are the necessary policies that are needed? So privacy, certification, to security policies, provider billing to support a virtual health strategy. So that's kind of how we're meshing together the Lumeca and Accenture implementation and change management as we go through our partnership and our journey of implementation. And I think I'll hand it over to Tom to close, and if he has any other comments.
Thanks, Cassandra. Well, maybe we'll pass it over to Marissa to open it up for questions.
That was a really great presentation. Such a great story. I don't know, for those who know that when I started with Digital Health Canada, I did the webinar Wednesdays, and I remember the first time Lumeca came on and presented was one of the first webinars I did. So I kind of feel a little bit bound to this story. I think it's amazing. Thank you both. We do have some questions in the chat, so I'm going to read those out. I believe this is probably for Tom. Do the physicians use their own EMR for their notes and just use the Lumeca for the video?
Yeah, the idea is to have their EMRs integrated, so calendar and patient data sync back and forth. In the one integration we pre-built into a Curo, we can actually push patient notes back, but most physicians are going to dual screen or split screen. But they're going to do everything that they would normally do in terms of billing and whatnot in their own EMR.
Okay, great, thank you. And the next question is, how did you decide where to place on-site solutions for the rural communities in Saskatchewan?
That's a great question. And hopefully next year when they start placing some, we'll have a better answer. The one that we placed with CowAssist, we had a partnership with CowAssist, and this was when we were a private walk-in. And so we have a great relationship with Chief Cadmus Delorme, our founder, Sean, and Cadmus. And so Cadmus, mentioned that was a problem they were having. They had no cell service. And so that's how the solution came about. But it was sort of a good dry run to prove that the technology could work. And to be honest, after we worked with SaskTel, it was pretty quick that they went out there and improved the service. And then nobody wanted to use the pod anymore because they were more comfortable doing their consultations from home. So.
Excellent. The next question is, what's the expectation for virtual care utilization and further development or innovation once the COVID rates drop? Do you think that there's going to be a slowdown in demand?
Well, I think a common sense answer to that, it'll be more than it was pre-pandemic, but less than it was at the height of the pandemic. And I think most people are in agreement. I think we're in this sort of maturation phase right now where we're figuring out what's appropriate. We're gathering data about, what things are best treated that way. And all of that is entering into a maturation phase. Don't get me wrong, we're still in our infancy in virtual care, but I think that basically outlines where we're headed.
And I think too, with like the specialty care, like remote home monitoring and, the rural remote versus urban, a lot of people with chronic conditions, they do live in rural and remote, and sometimes it's just not feasible, especially with the price of gas now, to drive 6-7 hours to an urban center for a 30-minute appointment. So I think in those instances, we're really going to be able to leverage virtual health and virtual care solutions to provide the best possible service to give those improve patient outcomes and quality of life.
Yeah, we all know it's not going to replace care, it's to augment. And
yeah.
With respect to interoperability and EHR integration, what solution or direction do you see as a way forward, say in less than 20 years? What specific mechanisms can move government funding, multi-vendor collaboration? Where they gave an example of Digital Health Canada or CIHI.
It's a great question. Cassandra, do you want to take a stab at that or do you want me?
I think you can start. I'm formulating a response in my brain.
Sure, sure. Well, I think interoperability is an interesting sort of problem to have because you've got business problems, you've got technological problems, you've got policy problems, and there's a sort of hairball that you need to untangle. So, I mean, you've got competitive problems on one end. So in some instances, some vendors might have a competitive advantage and not want to integrate. And so how do you move the needle to make them want to collaborate? And another side of things is, well, as a healthcare startup in digital health, sometimes that's an unnecessary cost without having a first contract. So it's a complex answer. I mean, number one, I think there needs to be funding in terms of programs for interoperability. I think that it's not just standards in terms of the data, but there also needs to be some standards in terms of the legislation. Basically, if you're going to play in this market, then you need to, at the very least, have the availability to integrate. You need to at least comply to the minimum standards. And I think that would be the starting point. But the biggest thing is we're moving to a cloud-based era, and we're moving to a SaaS-based era. And now we have to start contemplating subscription fees in terms of interoperability fees. There's going to be some monthly fees associated with that when you start budgeting and planning for that, because they need to be maintained. If they're going to be secure, then they need to be constantly improved and worked upon. That's the reality. We have to start budgeting for those things.
Yeah, and I think the multi-vendor collaboration is going to be key, as we learned from all the clinical information system implementations and DI systems and PACS and that type of thing. Those siloed systems don't work. And clinicians, what we're starting to hear is, if the vendor doesn't show that they can play nicely in the sandbox or collaborate with other vendors to integrate solutions, to build on each other's solutions, they're not interested. So that partnership between multi-vendors is going to be key in moving virtual health and interoperability forward.
I think that's a great point. Great points all around. I believe that brings us to the end of the questions in our chat. I want to echo a lot of the comments in the chat, which were thank you for a really energetic, very passionate presentation. We could really feel how strongly you're passionate about this project, and we appreciate that. So thank you so much. Thank you, Tom and Cassandra, for your presentations, and thank you for everyone who attended. Thank you for joining us at this P3 showcase. eHealth 2022 continues, so I invite you to join one of the sponsor symposia sessions 7 to 9, which you can access from the agenda section of the platform. Thanks so much, everybody. Enjoy the rest of your afternoon.